Heiner Wedemeyer actually is the director of the Department of Gastroenterology, Hepatology, and Endocrinology at Hannover Medical School in Germany. So as physician, clinician, but I can just mention that he has also worked as a research fellow at NIH in Bethesda in the earlier times, and then moved back to Germany. Well, is definitely clearly an expert in immunopathogenesis of hepatitis B, C, and D viruses. And what must be mentioned also here is that's being involved as investigator in really many different phase 1 to 4 clinical trial of antiviral drug immunotherapy for viral hepatitis, and I played, I think, a main role also in conducting especially the first Bulevirtide trials in chronic hepatitis D patient. So please, Heiner, the stage is yours, and we are looking forward for your presentation.
Okay, here we are. Thank you very much, Maura, for involving me. It's a great honor, and I'm really happy to see that you guys are putting Delta on your agenda in the forefront, which is obviously an extremely important topic. You asked me to present on current options of therapy, including adding interferon. That was basically what I'm asked for to present. But before starting, this is Hannover Medical School, let me invite you all to, if you want to know more about Delta, about this, to the second International Delta Cure meeting. Pietro Lambertico was inviting us to Milan last year, which was, I think, extremely successful. And this webinar also already highlights how important Delta is, that there are many, many questions, and it's really great that we can discuss some of these questions here during this symposium. So I'm really happy, and please consider to visit us in Hanover for the second meeting. It will be very nice, golden October in northern Germany. These are my potential conflicts of interests, which includes companies developing drugs against both hepatitis B and D. And I have to thank my long-term collaborators in Hanover at the Hepner Study House and also Cihan Yudhaidin. Maria mentioned already that we have new times in Delta. We have a new EASL clinical practice guideline, which was released during EASL on the Saturday of the meeting. And I think this is really a landmark document. It's for the very, very first time that an international association published a practice guideline on Delta specifically. And I can tell you that this was a hot discussion among the panel, as obviously not on all topics we have, let's say, long-term outcome studies, randomized trials. So this is really a clinical practice guideline trying to give recommendations even in the absence of very high level of evidence. So read it, criticize this, send your comments, which I think is important, because obviously a guideline is only as long as valid as until it has been published, and we have to work on the next version and to further improve this. The most important statement of this guideline was already mentioned by Maria, and that is obviously that all HBs antigen positive individuals should be screened for Delta, and I think that we should advocate. This is also what we are talking here, which is the topic of the seminars. But then obviously, if you have identified a patient, it's really the question, what can we do for this patient? How can we, what can we offer? And therefore, I like these recommendations, which are also very important and even strong consensus, even though the level of evidence is not high rank. So all patients with chronic hepatitis B virus infection should be considered for antiviral treatment. I think that is a very strong statement, very important. All patients with decompensated cirrhosis should be evaluated for liver transplantation. And also very important, even if a Delta patient has already developed hepatocellular carcinoma, this is not a no-go for antiviral treatment. And obviously we need to individualize strategies for these patients, but I think strong statements. And now, when you want to personalize treatment, which patient should receive what kind of treatment, it's also good that these guidelines highlight distinct factors being associated with a higher likelihood for a more benign course of disease or a more severe course of disease. And this includes host factors, but this also includes viral factors. Again, you see many question marks on these slides. This is what we have, but I think it's a very useful document. So I have to advocate these guidelines. And then when to consider which treatment, obviously in some European countries, we are fortunate to have Bulevirtide, and Pietro Lambertico will give you more details. But here, the other point is in other countries, we only have interferon available. And then it's a question how to combine this. And therefore, I really like this graph that if you aim for finite treatment, limited treatment durations, interferon is still the backbone of these treatment strategies. While if you have more advanced disease, if you may even consider prolonged treatment or undefined treatment duration, then Bulevirtide in our European countries is the preferred option at this stage. And as I will briefly mention, there are several other drugs and strategies in development. And for those of you who are not only happy with European guidelines, Lisa Sandmann and Markus Kornberg coordinated the German guidelines, and an English version of this German guideline is available since June 20. In most of the topics, both guidelines give similar recommendations, but there are differences. And therefore, this is quite interesting. So there's also a second document. And the most important statement that all S antigen positive patients should be screened for Delta is also part of our German guidelines. When we think about personalized treatment strategies for Delta, Delta is the devil, but we have to keep in mind that not every HDV infected patient may develop liver cirrhosis, liver cancer, and other complications. I think that's an important statement from my side. And this has been shown in different trials. For example, in the in the Swiss HIV cohort, yes, we have more severe causes. Delta RNA is important, but some patients have a benign cause. And in the Swedish cohort, this was very nicely shown that if you have not yet developed cirrhosis, over the next 10 years, your likelihood to develop a liver-related event is very, very low. Well, on the other hand, if you have already even compensated cirrhosis, Delta is really a malignant disease, as half of the patients within 5 years have developed or had developed at that time a liver-related event. So therefore, it's important to really identify factors to stratify our patients. Will my patient belong to this group or to this group? And I think this is really something we all have to work on together. Is it liver stiffness? Can it help? And maybe yes. At EASL, Lisa Sandmann presented one abstract really showing that, for example, a cutoff of 15 kilopascal correctly identified cirrhosis in 9 out of 10 patients. So, which is nice, but obviously this data needs to be confirmed in independent cohorts. I skipped this. So now what can we do at this stage? The question then is what to do with our old HBV drugs and Delta. Should all Delta patients be treated with tenofovir or entecavir? A question we have been frequently discussing during different meetings. The short-term answer and also the HDV guidelines say, yes, if HBV DNA is detectable, we probably should use it, but there's very limited evidence that we really improve long-term outcome. There are several single-center cohorts. This is an experience from the University of Essen, where I worked before I moved to Hanover. And you can see here those guys that only treated with nucleoside or nucleotide analogs have a severe or have a poor outcome. Interferon-treated patients have a better outcome, but obviously there's a selection bias because the better patients may receive interferon or with better profiles. But certainly nukes alone are not sufficient. Therefore, we have to go for interferon. Interferon has been used for many, many years. We published the HIT-1 trial 12 years ago. Roughly 1/3 to 1/4 of patients show HDV RNA suppression in the long term. Adefovir adding does not really help. but we also published that there may be late relapses in the long term. So I won't be showing patient 207, and this patient 207 experienced a relapse here 7 years after the end of interferon-based treatment. So we have to follow the patients, but I have to highlight that the patients being HDV RNA negative at the end of treatment, that these guys had a clinically good outcome, so they did not develop clinical complications. Prolonging treatment to 2 years does not really help. It does not prevent relapse. It's shown in the Lancet IBD paper 4 years ago. Then you ask, so if you want a personalized treatment, which are the factors being associated with response to interferon-based treatment? Lisa Sandman summarized many of these factors in Delta. I have to highlight that patients with compensated liver cirrhosis have a reasonable response. So do not exclude cirrhotic patients from the option of being treated with interferon. The IL-28B genotype does not seem to be a strong predictor of response in Delta. Viral genotype, some very weak data that genotype 5 may be associated with a slightly better response from France and from King's. But this may be biased by other patient factors. Viral load obviously is a good factor. Low viral load is better than high viral load as for other infections. Let's say personalized response-guided treatment with viral load during treatment may have some benefit. Viral dominance patterns are not really something that can be used in clinical practice, and there may be even other factors like immunological markers. Let me just tell you that, for example, also HBV markers like correlated antigen levels have been studied in Delta, may be used as response factors. So there are, if you use interferon, look to the literature. This paper is recommended to you. One last remark, use also, when you use interferon, the most sensitive assay available. For example, if you use a more sensitive assay detecting low viremia, then your risk to experience a relapse after the end of treatment is much higher. So this is when we retested the old samples, where we used an in-house assay with a more sensitive assay. We identified patients with low viremia, and these guys had a higher risk for relapse, which you should consider in this context. Bulevirtide, Pietro will mention this. It's approved in Europe. We have the short-term trial, Lancet ID, published in January. We have the New England Journal paper with a phase 3 trial, which was published in June, and Pietro will show you the respective data. It's certainly an option which is available. I will skip, for time reasons, Maura, some slides, just to let you know that other ideas are in clinical development. Lorlatinib is the prenylation inhibitor, which can be used also in combination with interferon. We saw here data of the largest trial in Delta ever being presented at EASL. They are publicly available since a press release in December 2022. Lorlatinib alone or in combination with interferon. These were the data that we saw also in EASL or during EASL. And you can see here that with lorlatinib treatment alone, you have this loss of response during treatment, some kind of breakthroughs. There is an additional synergistic effect if you combine both drugs, interferon and lorlatinib. This is certainly something which needs to be followed. Off-treatment data were presented by Dr. in Vienna, which is interesting, that post-treatment week 24, there were, let's say, the response numbers were largely maintained, which is, I think, interesting. So off treatment, we did not lose many patients, but also here we need to understand which patients will in the end benefit from this treatment. We have data on nucleic acid polymers. I do not have the time to go in detail here. We saw these data frequently presented 10 years ago for the first time, and we have additional case reports presented during recent meetings and case series, which are quite interesting, and we may discuss later during the discussion. And lastly, as siRNAs against HBV are also explored, I had the privilege to present during EASL the REEF-D study results, and you can see here that S antigen, if used as RNA, are also declining in Delta, and that is very important. This parallels HDV RNA decline. Even though these patients still have a high S antigen level in absolute levels, they lost or they reduced HDV RNA, but this was associated with significant ALT flares early during treatment, but in the long term, these patients benefited. And you can identify a subgroup of patients with low S antigen levels, which did not experience these flares. These are the blue guys here, and they had really long-term benefit from these treatments. So Maura, let me finish here. So I think PEG interferon is still the standard of treatment for hepatitis D for most patients worldwide. Pietro will address some Bulevirtide-related questions. Additional new treatments are in clinical development, but what is quite clear for Delta, we really need personalized management approaches. I think that's clear. There will not be one size fits all for every Delta patient. And again, if you want to discuss these options, we invite you again to Hanover in October. Thank you very much.